Today, I will talk about Aichi Spine Hospital developed a new PELIF method for spondylolysis and degenerative spondylolisthesis with or without canal or foraminal stenosis. There are three categories in endoscopic surgery. The first category is fiber or needle operation for mild degeneration. The second category is decompression surgery, such as PD, MED for disc herniation. MEL, PSLD, or UBE are used for stenosis. The third category is fusion surgery, which includes our original PELIF, MELIF, and others. Our developed MELIF and PELIF approaches are indirect decompression methods. This figure shows other fusion approaches. This is the PELIF approach. These approaches are for regular TLIF, PSLDF, and UBELIF. SLP must be cut off. The spinal canal must be invaded, so dural damages tend to be occurred. These are XLIF, OLIF, and ALIF approach, of which the good points are no canal invasion, posterior muscle preserved. However, these methods have risks of damaging the intestine, ureters, and vessels. MELIF approach is from more lateral than PELIF. This approach is similar to the transfemoral method. The opposite side incision is only to insert sextant pedicle screws. It needs decompression of lateral side of SAP and total discectomy. The spinal canal is not invaded. However, not under continuous water irrigation. Endoscopic view is not so clear. The other original approach, PELIF, is similar to MELIF. PELIF needs unilateral decompression at hand in the safety triangle, like percutaneous endoscopic discectomy. It needs no bone resection, no muscle retraction, and no canal decompression. So, no dural damages and no internal organ damages. PELIF is clear vision and continuous water irrigation, and the least invasive with 5 incisions of each around 1 centimeter. Fusion surgery has many complications. Since PELIF has much muscle detachment, it tends to cause not only postoperative muscle atrophy, but also adhesion to the dura mater and nerve damage. TLIF tends to cause nerve or dural damage. Since XLIF retracts psoas muscle, it tends to cause L4 root palsy and intestine rupture. OLIF tends to cause ureter damage. ALIF tends to cause vascular damage and ejaculation trouble. PELIF complications are rare. PELIF is similar percutaneous endoscopic discectomy and simple method. Overall procedure of PELIF. Step 1, collect the harvest bone from the iliac using the trifine, and artificial bone substitute is also mixed. Step 2, total discectomy through unilateral cambio safety triangle and the percutaneous full endoscopy. Step 3, the end plate should be scraped off by our original outer sheath cutter. Step 4, intervertebral cage insertion. The cage packed with bone chips is inserted along the L-shaped retract slider, which protects the exiting root. B, the expandable cage is delivered along L-shaped retract slider. All types of cages are available. Fixation with screws. Hybrid cancelled screws are used for less instability cases. B, PPSI digit fixation for much instability cases, such as spondylolysis or spondylolisthesis. Aichi Spine Hospital developed PELIF is performed using a full endoscopic conventional use for discectomy. Firstly, start by harvesting cancerous bone chips from the iliac crest using a trifine via an 8 mm incision. Total transfemoral discectomy is easily performed through safety cambio triangle. The unilateral approach is used to sufficiently remove the nucleus and in the plate using the outer sheath cutter. One cage is transmitted into the intervertebral space along the special designed L-shaped retractor slider. In case of a highly instability such as spondylosis or spondylolisthesis, it should be fixed using stable pedicle screws. 4 incisions are 1 centimeter, and 1 incision is 5 millimeter, which are minimally invasive operations for the patient. How to harvest the cancerous bone chips? Firstly, set the image in the spire 30 degrees to the head side and 30 degrees to the opposite side, and project the teardrop image on the monitor. A gem-sealing needle is inserted to the iliac crest. A needle aspirates bone marrow blood. Collect the cancerous bone chips from the iliac crest using a telephine via an 8 millimeter incision. Forceps is also useful to collect the bone chips. Push out the bone chips from the telephine onto the petri dish. Mix the cancerous bone with bone substitutes are padded into a cage. Mixed bone chips are padded into an 8 millimeter flat outer sheath. Mixed allograft bone is padded through the cannula into the disc space. Mixed cancerous bone and bone substitute. This is hydroxyapatite and the collagen hybrid substitute. Superpour is phosphate calcium. Aspirate bone marrow fluid firstly. Bone marrow fluid is mixed with bone substitute. Connect an air suction tube to the bottle of bone substitute to promote bone marrow fluid infiltration and negative pressure. After the mixed allograft local bone is padded from the same bottle, the P cage filled up with hydroxyapatite collagen hybrid is transmitted through the portal. A. Total discectomy and end plate resection through Cambin's safety triangle. B. In the unilateral approach, the endoscope is inserted to the disc space, red circle, at 45 degrees. And then the endoscope can be tilted widely from 30 degrees to 70 degrees to create a wide range of the mother bed yellow circle. However, in L5S1, its range of motion is limited, so bilateral approaches are required. If there is foraminal stenosis, foraminotomy has to be done to prevent the existing damage during the insertion of a cage. Or there is a radiculopathy due to lateral recess stenosis or herniation, ventral fastectomy is necessary. It is important to rationally remove the entire disc and end plate. The outer sheath cutter has been improved based on the duckbill outer sheath. Each tip is wedge-shaped at 45 degrees. Rotating the cross handle is effective for scraping the end plate thinly and aggressively. The scraped end plate and nucleus are then removed with forceps. The endoscope can be tilted widely from 30 degrees to 70 degrees to create a wide mother bed. The compression maneuver is performed from one side with wide foramen or radiculopathy to the other side, and from posterior to another. Let's show the resection area on CT. Insert outer sheath cutter from the posterior lateral and perform discectomy and end plate resection of the ipsilateral. Then tilt the endoscope horizontally to decompress the contralateral and dorsal side. Wide range of discectomy and end plate resection can be performed by tilting the endoscope appropriately. At L5S1, ROM of the endoscope is limited, so bilateral approach must be performed. It is important for a bone fusion that the end plate should be scraped off to the extent that light bleeding is observed. The outer sheath cutter is an evolution of the conventional 70.5 millimeter duck bill outer sheath. By rotating the thin surface layer of the hard end plate can be scraped off. The tip is sharpened at both ends of a 10 millimeter duck bill. Each has 45 degrees blades. Another expandable blade cutter smooths the remaining irregularities of the roughened end plate. First, it is inserted with the tip closed and is expanded in the disc space to remove the remaining disc material in the concave end plate. The flexible diamond burr is useful to do drilling of the end plate under endoscopic view. Finally, the expandable blade cutter is inserted with the tip closed, and then the expanded tip can smooth any remaining irregularity on the end plate. The flexible curettage can also remove residual cartilage tissue. As a result, a smooth mother bed can be created with continuous water irrigation and a full endoscope. It's important to remove the entire intervertebral disc and end plate. First, remove the intervertebral disc from the ipsilateral side with forceps and the endoscope. A flexible diamond burr helps to shape the end plate within a narrow outer sheath. Then rotate the outer sheath cutter and scrape the end plate thinly and actively. At L5S1 level, a surgeon or assistant stands on the contralateral side and decompresses. In the same way as the ipsilateral side, remove the intervertebral disc with forceps. By rotating the outer sheath cutter, the thin surface layer of the hard end plate can be scraped off. Remove the scraped end plate with forceps. Finally, the expandable blade cutter is inserted with the tip closed and then is expanded in the disc space to remove the remaining disc material in the concave end plate. How to insert the cage. This figure shows the relationship between the cage insertion pathway and the exiting route. First, the intervertebral disc space can be in the triangle is decompressed to make it easier to insert the cage. L-shaped retractor slider is inserted into an 8 millimeter outer tube. Round corner of the L-shaped retractor slider protects exiting route. The folder with the barrette cage filled with the substitute bone is sandwiched between double L-shaped retract sliders, allowing easy passage through the skin. Immediately after the tip of the barrette cage reaches the disc space, remove the caudal retractor and advance in the cage to 1/3 of the disc space and the fluoroscopy. Since to 0.5 millimeter L retractor sliders may close diagonal contact with both sides of the cage, it only increases the thickness of the two metal by 1 millimeter. The metal fitting will gradually increase the intervertebral height while flexing and while protecting the exiting route. The cage passage in the muscle is performed smoothly. The cancer screws are fixed for less instability, such as modic change, DDD, and L5S1 foraminal stenosis. PBS are used for much instability, such as spondylolysis and spondylolisthesis. Even in the case of PPS, The endoscopic portal and lower PPS portal can be shared, so it is limited to 5 small incisions. Less instability cases are fused using a hybrid facet screws method. Indicate case 1 is modic type 1 changes that is confirmed with T2 high intensity of MRI image. Degenerative disc disease shows chronic low back pain with intradiscal massive vacuum that temporary pain relief is achieved with the disc block. Indicated case 3 is when bilateral foraminal stenosis due to decreased disc height is accompanied by low back pain and radiculopathy. 2 transfacet screws are easily loosened, and each translaminar screws tend to interfere. The new original hybrid system eliminates the disadvantage of easy loosening or interfering by combining a transfacet screw and a translaminar screw. Degenerative disc disease occurs continuous chronic disable pain for a few months. In the situation such as no effect of painkillers, rehabilitation and tranquilizer, and temporary effectiveness of intradiscal injection, percutaneous endoscopic transforaminal lumbar interbody fusion, PELIF, with hybrid facet screws is recommended. This 75-year-old male has continuous bilateral anterior side pain and severe low back pain. He had also L1 vertebroplasty due to severe osteoporosis before. PELIF was performed at L3-4 with hybrid screws facet fusion. CT shows right transfacet screw. Left translaminar screw was inserted from right side through the lamina to left. This 76-year-old woman had severe low back pain and moderate bilateral lower leg numbness with 300-meter intermittent claudication. Image showed L4-5 degenerative disc change and mild spinal canal stenosis, but no instability. After percutaneous endoscopic discectomy by the transforaminal approach, PELIF with hybrid facet screw fixation was performed and her symptoms and MRI improved completely after 2 years. Much instability cases are fused using rigid percutaneous pedicle screws method. Indicated case 1 is spondylolysis accompanied with severe low back pain. Indicated case 2 is spondylolisthesis in more than myelin level 2, or severe low back pain in even if myelin level 1. Even in the case of PPS, the endoscopic portal and lower PPS portal can be shared, so it is limited to 5 small incisions. How to insert PPS? There are 3 key points of needle advancement. PPS entry pathway must be decided under correct AP and lateral floor image views. The jump city needle entry point is at the outer upper quarter of the pedicle under AP floor view. The needle is set at the posterior line of the pedicle. As can be seen from the CT image, the tip of the needle is at the outside and beginning point of the pedicle. PPS midpoint is important. In AP view, the tip of the needle must be inserted till the medial line of the pedicle. In lateral view, the needle tip must be set at the posterior line of the vertebra and midpoint of pedicle. CT also shows the same position. PPS terminal position. The final target point of PPS is slightly lateral, the center of vertebra, in AP view. In the lateral view, the needle tip is anterior 1/3 of the vertebra. In CT, the tip of the needle is slightly lateral, the center of the vertebra, and is 1/3 of the anterior. Procedure to insert PPS. The jam-CD needle is inserted into the lower pedicle via shared lower portal. The guide wire is inserted into the jam-CD needle. The same procedures are performed into each other pedicle. Tapping maneuvers are done for each other pedicle. PPS is inserted into the pedicle. The length of the load is calculated. Insert the appropriate length load subcutaneously. Fix the load with the set screw. Check the PPS fixing position and the floor image. This patient was a 51-year-old man with continuous numbness on the posterolateral area of both sides with 200-meter intermittent claudication. Expandable spacer elevate can minimize insertion force, provide controlled distraction, and optimize end-plate to end-plate fit. The PELIF mother bed can accommodate cages of various shape and is unlimited. This patient was 71-year-old male with severe low back pain. The L5-6 disc was hollowed out. Nucleus disappeared and instability was occurring. Resection of disc and end-plate were done. A cage was sandwiched between double L-shaped retractor sliders. The cage was inserted along L-shaped retractor slider. PPS were inserted. Bone plantation was done. PELIF relieved back pain. This case had light sciatica and back pain during work due to L4-5 degenerative spondylolisthesis and instability at L4-5. After PELIF, symptoms had disappeared. The PELIF surgery time was 2.5 hours. Blood loss was 30 milliliter. Post-operative X-ray and MRI sagittal views showed good correction at L4-5, and the PPS system and cage were in a good position. 3 months later, the MRI actual view showed that the spinal canal was moderately expanded due to the extension of the redundant yellow ligament. 1 year later, the spinal canal was further expanded due to shrinkage of the hypertrophied yellow ligament. Lide's intraleaf system is also a very good method. After making the mother bed, expandable cage is delivered into an 8.5 millimeter outer tube or L-shaped slider. This patient is a 51-year-old male with spondylolisthesis. Expandable lumbar fusion device LIDES was inserted into the intervertebral space at a contracted height. When it is expanded in the disc space, the implant can lift the upper and lower end plates to the appropriate height. Postoperative images show good correction. This female patient suffered from bilateral sciatica and 100-meter intermittent claudication. L4-5 showed lateral instability and disc space was narrow with disc herniation, light L5 root damage, and left extraforaminal disc herniation, left L4 root damage. Firstly, discectomy and end-plate resection were performed from right wide disc space, and then left extraforaminal discectomy and end-plate resection were done from left side. After PELIF, intermittent claudication and bilateral sciatica almost completely disappeared. This patient was a 71-year-old male. He had moderate back pain, 20 millimeter intermittent claudication, and severe right sciatica. CT showed right foraminal stenosis at L5S1 and spondylolysis. MRI showed also right L5 exiting root compressed PELIF was performed. Right foraminotomy and insertion of the cage increased vertical distance of the foramen. This patient was a 46-year-old manual laborer with spondylolysis of L5 and spondylolisthesis at L5S1. At the L5S1 level, the iliac limits endoscope tilt. Therefore, it is not possible to completely create a mother bed only through one portal. Bilateral cambridge approaches can create a complete and wide mother bed. This case is spondylolysis and listhesis at L5S1. Two cages are driven in from both sides, and heavy worker needs stronger fixation. The narrow L5S1 disc cavity has been raised and fixed. Conclusion: characteristics of PELIF. Create a mother bed under the endoscope from canting triangle with an outer cis cutter. Discs and end plates can be removed from one side. However, bilateral approaches must be done at L5S1. The iliac cancellous bone can be sufficiently corrected with an 8 mm incision. Continuous water irrigation makes clear vision. This instability cases such as DDD or modic change can be used with the translaminar screw and the facet screw. But instability cases such as spondylolysis, listhesis need PPS fusion. L-retract slider can protect the exiting root. Beerless type of cage can be inserted along double retract sliders. No muscle retract, no bone dissection, no canal decompression, indirect method. Herniation and lateral recess stenosis can be decompressed directly. No dural tear, no internal organ damage, no large vessel rupture. The fourth isthmus, Asia-Japan, combined with the 14th Smith Summit Forum, will be held online from March 25th to April 24th, 2022 next year. Welcome to Japan from beautiful Maiko-san.
Thank you.